It's one thing to have HIV prevention medication available for use, but to get people to use it is an entirely different story. Joining me online to discuss this is Professor Linda-Gail Bekker of the Desmond Tutu Health Foundation at the University of Cape Town. She's also an infectious diseases specialist. Linda-Gail, thanks very much for making the time to join us today. When we started to use PrEP, the oral pill, in South Africa in 2016, the uptake was pretty slow. Why was that?
Hi, Mia. Always happy to chat to you. Indeed. When we started in 2016, if you recall, the strategy was to try and make it available to what was considered the riskiest populations in the country. And that sort of went down the lines of key populations, namely men who have sex with men, sex workers, those populations. And I think that had two important implications. The one was it stigmatized the prevention methodology. The second was it caused the sort of othering attitude of, well, this is for other people, not for me.
Now, since then, more options have become available for HIV prevention, and we now have 3 types of medication we can use. Can you just break them down for us?
So the first, as you say, the first iteration was an oral pill. It's a two antiretrovirals in one tablet. You swallow 1 pill a day is the concept. And you take it as a person not living with HIV as protection against HIV. The second one that came through randomized controlled trials, a vaginal ring. So the ring is made out of silicone. It is infused with an antiviral called dapivirine. You insert it into the vagina. It can be self-inserted or inserted by a healthcare provider. And it sits very comfortably at the top of the fornix, right under the cervix. And over the next 28 to 30 days, it slowly diffuses the antiviral. So it's a brilliant concept. You have the antiviral right there where the business happened. And then the third agent is much newer. This agent is in an injection. It's an intramuscular injection, which has to go into the butt. It's quite a lot of volume, so it's got to be given by a trained professional. And that, brilliantly, only has to be done every 2 months. So every 8 weeks, you need to come in and get your next shot.
Now, the health department at the moment only distributes the pill, and I know that the vaginal ring is in implementation trials at the moment. But if you look at efficacy, then the pill seems to be more effective than the ring. So an average person would ask, why would anyone then choose the ring?
You're quite right, Mia. Oral PrEP is for all populations, highly effective in all populations if taken as prescribed. What's the difference between the ring and the pill is that I think, the ring is topical. It is in the vagina. Very little of it gets absorbed systemically. So there are very few side effects that are systemic. And I think it's going to come down to choice. Do I want to swallow something daily, or do I prefer to use something that is on the outside, if you like, but on the inside in terms of the vagina, but you don't have to actually take it into your system?
If we look at the injection, then trials have shown that it works better than the pill, and we will be receiving some of those injections in South Africa for implementation trials early next year, and you're running one of them. How are we going to know if people will actually use it?
That's exactly what these implementation studies are designed to do. The fact that the clinical trials are one thing, they tell us whether the product actually works or not. Thereafter, you've got to kind of do the real world experience. When you put it into clinics within our health system with all of its ups and downs and in-betweens, first of all, will people come? How many of them will prefer which one? And will they actually use it as prescribed? The implementation science or the pilots really lets us do the real world thing, but in a carefully monitored situation.
Now, one big problem with this injection is its price. It is really, really expensive. I know that it sells around 70,000 rands for one injection in the United States. But VIV has just announced recently that it will sell it at a non-profit price between 540 and 570 rands for countries like South Africa. But that is still too expensive for our health department because it's far more than what the pill costs. So what now?
First of all, we have to say, and I hear that affordability is really important, but we also have to say it's very expensive for young women and girls and young men to become infected with HIV, to learn their positive status, because then we do need to provide them with antiretrovirals, and that's lifelong antiretrovirals. Plus, it's all the cost of living with the virus. So I do think it's not just how much does it cost, but how well does it work, right? How much is the price or the value of saving someone from an infection and therefore giving them a better handle on a healthy and lifelong future. Having said that, we know that the price of these commodities come down as we take things to scale, as we use them. But I do believe there is a period before we get to that point where we've got to get the product into the country and use it. And that may need donor funding. It may need our friends at PEPFAR or our friends at the Global Fund to help us to be able to get those numbers up, get people to use these products, to understand what the value add is to our country. I believe it will be a lot. I believe it will make a difference to our epidemic.
Thanks, Linda-Gail Bekker, for your time and for your insight.